Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before we get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. So, avatars help reduce social anxiety. Tell me more.
Think of it like, I don't know if you remember the Muppet Show, like back in Jim Henson. That actually was inspired by therapists. Did you know this? That puppetry was used as a form to provide therapy to traumatized children, foster kids. And that actually, there was a lot of research behind it, using puppets as a way to communicate. The therapist would be able to communicate to a child using a puppet to get them to talk. It's one of those populations, where they're severely traumatized. A lot of them are mute. They don't have the resilience after going through, like I'm talking about really like refugees, kids that have been sexually assaulted or beaten. Anyway, I took that idea and used it in conjunction with what Skip Rizzo did with Brave Mind. So he uses an avatar to talk to the veterans, because a lot of PTSD, being diagnosed with that, they are adverse to going in person or not even showing up to therapy. So that's where the idea stems from. And there's a lot of clinical research behind that.
So you're taking the ideas of Jim Henson. Yeah, you've got Muppets from the previous century that were engaging with children and puppets, and you're basically digitizing it. You're basically saying children talking to an avatar perhaps have a better outcome than, from a therapy standpoint, than they're talking to somebody who is a person.
Another layer of that is if I can allow my patient to choose, have the empowerment to choose what I look like, there's a lot of efficacy in that, because think that you're like a 12-year-old preteen male and your parents are forcing you to go to therapy. It's really intimidating, especially if it's a stranger, or maybe like even like you don't feel comfortable around women or a male or whatever. If the patient can have the opportunity to actually change what the therapist looks like, it does create a psychological comfort zone. And we're not taking away like me or the therapist or anyone, like the licensed provider. We're not taking away that person. We're just taking the persona, like what that child is seeing. But they're hearing my voice. I'm still delivering the same clinical care. I always try to explain this to people. You don't want to remove the actual true therapist. We're using a tool to modify what the therapist would look like, but there is empowerment for the patient when they can choose what their provider looks like. I'll give you an example. My case that was during the COVID years, I mean, she was 10 years old. She was being beaten by both parents. Everyone was in shutdown, right? Like everybody, there was stuff going on people do not want to hear about. Especially, I'm from the Bay Area, and there was a lot of stuff going on. And it was a CPS report. And, she had in the beginning when I was just doing Zoom telehealth, it was awful. Like she wasn't present. She wasn't concentrating. She didn't really talk. But once I put the VR headset on her, she was a lot more engaged. And so what I proved with that engagement was she felt not just with the cognitive delivery of care, but also with her body, because you're embodied in this avatar, almost like a second self. She felt a lot more at ease and calm, because I'd always check in with her. I go, "How do you feel? How do you feel?" I said, "I feel a lot calmer and I feel safer." Now, to a child, to say that in therapy is a breakthrough for us, right? It's very exciting because it shows that they're making progress. And when I was making like a real breakthrough with her, she was coming to terms with, not being afraid of adults. It's like she would keep asking me to be a teddy bear. And then there was at one point where she started, she didn't really talk about the abuse very much until the last couple months of her treatment. But what was breakthrough about it and very compassionate was like she actually would in VR come up to me and give me a hug. That's what therapy, yeah. And think like this is the cool part, Omkar, is think that, I'm in a completely different city than her. This is all done remotely. We can't do that over a Zoom call, right?
Yeah.
It's taking it to another level of using the technology to truly heal, right? So that's phase 1 right now where the product is. And to answer the first question is like, where is the product going? So phase 2, version 2 is we're going to add heart rate variability biometric tracking. And what that is, this is a scale from 1 to 100 using a wearable that pre and post session, we take a reading of the HRV of that patient. And what that allows us providers to see is like where is their automatic nervous system? Like where are they at in terms of like safety? And that's a really important measurement for using in telemedicine because we can't really see what's going on in their body, right? When we're just doing a Zoom call. But if, say, I'm working with a child that is anorexic or using substances, that HRV reading is really reliable to see what their vitals are. When I say vitals, I mean like their automatic nervous system. Because if they're anorexic, that V is going to be dangerously low. Or if they're using fentanyl, it might be super high. Like it really depends, but it's a measurement. And then over the course of treatment, the goal is to see that HRV levels to improve. And that's just the new tool that we're adding into the product. And then on top of that, we're going to incorporate an AI translational tool that when I have my session, nothing is captured during the VR session. So a therapy session Encore is usually between 45 minutes to an hour. During that, it's all HIPAA compliant. Nothing is stored in a cloud, nothing. It's all kept up here. And after session, our job is to write progress notes to capture the story of the session. And that's a lot of burden on a therapist. So we're going to use a translational AI tool that I can speak into after post session, which will automatically do my progress notes. And then I can move on to my next patient. And that's a value add for having a higher caseload, especially for outpatient hospital systems, which is where I come from.
Erin, thank you so much for joining us and for all the great work you're doing with TheraVR.
Thank you.
Robots are fascinating. And in our world today, there's so many different use cases I'm seeing pop up left and right as we think about robots and how they're interfacing with our society. You've introduced the world to Robin years ago. Tell us more about Robin and what Robin does, and then we can dive more into the origin of it.
Sure. Robin is a social robot, and we built Robin to be a friend for pediatric patients when they undergo their medical procedures or they're undergoing their treatments at the hospitals. And we started this 6 years ago. It's almost 7 years. And our goal was to, as I said, create a friend. And Robin uses variety of techniques to help patients, social emotional support, medical education, entertainment, playing games, explaining medical procedures. We have more than 40 robots already in medical facilities around the country. And we see how kids and patients create meaningful relationships with our robots. So that was the rewarding part.
I've noticed you say relationships and friend multiple times, and I'm guessing those are deliberate word choices. Tell me what the emotional connection between the child in the medical setting and Robin the robot is, and why that emotional connection, friendship, is crucial and different than other words you could be using.
Yeah. If we try to imagine what the kid is experiencing when they're in the hospital, right? So they're away from their home. Usually they don't have much control because doctors, medical staff tells them what to do. Parents in high stress environment, again, like the kid is just listening to what they need to do and just adhering to it. And they don't have friends there. Of course, staff and family try to do their best, but in reality, they don't have friends in the hospital. The world that we're creating, that now this kid who was admitted into the hospital have a friend. And Robin is a 7 years old child. And Robin has a personality of a 7 years old. And with Robin, they gain back their control because they can teach Robin. Robin doesn't know everything. They play together as peers. And a space that is being created is healing because now they have a companion with that. And challenging moment that they are experiencing, now they experience with Robin. And let's say they have a painful procedure coming up, Robin can talk to them and show that same procedure and tell them that have done this procedure too and explain what is going to happen, what is the experience like. And we see that creates relationship because they are peers, and also the compassion and empathy that Robin provides is very crucial. And of course, most of the time they have fun because hospitals, CHL is a great hospital, but it's not a fun place in general, right? So they are having fun together. They are talking about their favorite character, games. They play games. Robin plays music. So they have this peer with them.
Robin is voice enabled.
Yes, yeah. Robin
And
talks to them
and she understands what they're saying as well.
yes, yes.
And now, these days, I imagine with generative AI, you're able to generate all sorts of content in essence, generate narratives using the newest technology. Tell us about how some of the new AI technology is being built into Robin.
Yeah. So the technology that Robin works with, we call it human assisted AI. So we have teleoperators that are in control in the all the interactions that Robin is having. So we specifically designed this system in order to be able to maintain high level of interactiveness in this high stake, very sensitive conversations. Because as much as I love AI and I'm excited about capabilities of large language models, but they are not able to analyze and consider all the context that is going into a conversation with a child in a healthcare setting who is scared or who is sad. So that's why we have human operators who are trained and have clinical backgrounds to facilitate and orchestrate every interactions that Robin is having with children. And this way it becomes a human-like experience where we can consider even slight changes of the mood or like very subtle nuances into that it goes into conversations.
Very interesting. So when a child is talking to Robin, there's a human operator that's somehow understanding what that
Yeah.
conversation is being held. Is this happening in real time?
Yes.
Wow.
Throughout these years, we were in the field for over 6 years, as I mentioned. We learned from children what they like and what content works, what strategies work in different type of scenarios, how to prepare kid for medical procedure, how to prepare kid for MRI, what is the best way to cheer up the child if they're scared or they're feeling lonely. So throughout the years we collected this data set and strategies. Our clinical team worked to create the strategies for Robin that we see 90% of the time we know how Robin should respond in order to address certain situations in the hospitals.
Are there any stories you can share about an instance where a child was scared or really needed that companionship and Robin saved the day?
Yeah, there are many stories. I think the one that comes to my mind is there was a kid who was refusing to eat, and it was very important for clinical staff to make her eat. She was refusing to eat for a couple of days, and Robin went there. They played together, and Robin said, I need to go recharge my battery, and it will be great if you recharge yourself too. And in order to make Robin happy, this kid started eating, and people were amazed. Okay, wow, that's the power of friendship, right? I think that we
Yeah.
get stronger when we get that encouragement. Another situation I recently learned from our partner facility, kid who was in a rehabilitation program, and they are trying to make him walk, and it was painful and it wasn't easy. So they made Robin to walk with him to encourage during the therapy procedure, and he did it, and it was very fun. And we see clinical benefits to what Robin does.
That's amazing. Karan, the work you're doing is incredible. And I think every story that share about Robin and the impact that she's having in patient care and improving the experience of families is amazing. So thank you, and thanks for coming on the show.
Thank you, Omkar. Thanks for having me.
So tell us a little bit about the problem you're solving and how you all got started with solving this issue.
We came together as a group. We all have different expertise, and all of that expertise is required to solve this problem because it is a big problem. We actually are putting wearable sensors on babies in the neonatal intensive care unit. We're doing that because we want to be able to quantitatively measure movement patterns. And we actually have a couple of different outcomes of interest that we're looking at. So the short-term outcome is improving the prediction of sepsis in the NICU. The long-term outcome is improving the prediction of neurodevelopmental outcomes for children at 18 to 24 months. So we're hoping to use the data that we collect from the babies in the NICU for these two different analyses. And of course, one will take much longer than the other because we will need to wait for the babies to grow up.
So what led you to this? How did you get the idea to get this study off the ground?
We know that infants in the neonatal intensive care unit are at risk for a number of adverse health events, health outcomes, both during their time in the NICU and for many years after. And, we are interested in identifying very early which children are on which path. Can we identify who needs interventions in a personalized way as early as possible? And we're interested in adding movement sensors to many of the other clinical assessments that we already have in place, So again, one of the problems that we're focused on is sepsis in the NICU, and I'll let my colleagues talk a bit more about that. And then the other one, again, we're talking about is the focus on the long-term problem of neurodevelopmental outcomes for these kids. And the way we got together on this was I was at the Pediatric Academic Society meeting and stopped by a poster that Will was presenting, and we had a great conversation and had this idea, and it only took us, a couple of years to pull it together. But as soon as we started identifying, we had this idea, then we needed to find our partner in the NICU. And so we reached out to Molly and engaged her in the conversation. And we've been planning and collaborating ever since.
I run a company that specializes in predictive analytics for neonates, patients in the neonatal intensive care unit. Our device called Hero predicts sepsis based on abnormal heart rate patterns that are early indicators, sort of an early warning system, an autonomic response to cytokines and the early phases of the inflammatory process that can be used as an early warning for sepsis. We're always looking at new research opportunities. Actually, I'm collaborating on a project to quantitatively assess opioid withdrawal syndrome among neonates, so NALS, which is where I had a poster and started talking with Dr. Smith and understood from her expertise on collecting motion sensor data from infants. And of course, one of the major indicators of sepsis is lethargy, for example. And I was aware of other research indicating that motion artifact in ECG leads or camera-based motion detection is another important predictor of sepsis. further understood from Dr. Smith that she was using this motion data to assess cerebral palsy years down the line in these patients. And of course, sepsis, again, is this trigger that some of our research has shown is an important trigger of the inflammatory cascade and process that ultimately leads to neurodevelopmental impairment among these patients as well. So we've got this nexus of ideas: inflammation, cytokines, sepsis, inflammatory burden, and long-term neurodevelopmental outcomes. That's what led us to be excited about this project and bring Dr. Easterlin in to collaborate and be the real expertise on actually managing these patients and understanding their outcomes. And ultimately, what we hope to do is enhance our predictive models of sepsis and neurodevelopmental impairment with this motion sensor data that we'll be collecting from the NICU and CHLA.
And then maybe just to tie that into the clinical context. So infection is sort of a constant concern in the NICU, and really for three reasons, I would say. The first is that, as my colleagues have alluded to, infection is associated with both worse outcomes in the short term and the long term, the most feared being death, but other comorbidities like chronic lung disease, and then longer term, having developmental impairments. The second reason we worry about sepsis is we know infants in the NICU are at high risk for infection, and that's because, one, of prematurity. So rates of infection vary by gestational age and birth weight, with the smallest and youngest infants having the highest rates. But even in the NICU, term infants are also at increased risk of infection because they need invasive medical devices like central lines and breathing tubes, which they need for their care, but that also increases the risk of infection. And they also go through procedures, which can increase the risk of infection. And then the third reason we worry about infection in the NICU is because the clinical signs and symptoms are very nonspecific. So a baby may show some signs, but they could be related to infection or something else. So things we look for are changes in their vital signs, so changes in their heart rate, changes in their ability to regulate their temperature. It might be slightly lower or higher than usual. They might breathe slightly faster than usual. They might work a little harder to breathe. They may not want to feed by mouth or tolerate the feeds we're giving them, or they just may be a little bit more tired and less active. So from a clinical standpoint, those can be difficult signs to attribute specifically to infection versus something else. And then from a laboratory standpoint, we look at markers of inflammation, but these are also nonspecific. So we look at things like the white blood cell count, the types of cells that are responding to infection, and then markers of inflammation. But again, these are nonspecific to infection and can be elevated for other reasons.
What is the current standard of care as it relates to sepsis detection in the NICU?
So currently, when we're concerned for infection, we will typically draw cultures. These are bacterial cultures looking to see if we can grow the bacteria from the blood, the urine, and sometimes even the cerebrospinal fluid if we're worried about meningitis. We'll draw these cultures. They take about 2 days or so to grow the bacteria. And while we're waiting for the cultures to result, we typically start broad spectrum antibiotics to cover for any of these serious bacterial infections. We'll also draw some labs to look at the white blood cells, some markers of inflammation. But typically, we leave babies on broad spectrum antibiotics until we have results from the blood cultures. If the blood cultures come back negative, we can often discontinue the antibiotics if the baby is clinically doing better. If the cultures come back positive, we continue the antibiotics, and hopefully, as we get specific results in terms of the bacteria and the resistance, we'll narrow the antibiotics to try to target the specific organism growing. But it does result in babies receiving quite broad spectrum antibiotics for often a few days, even if the cultures are negative.
So if the study demonstrates a correlation with the motion sensors, conceivably you could see a change in standard of care in the future where you're able to use sensor data to better predict who needs more timely intervention, but also perhaps it shifts the amount of antibiotics given to the population in the NICU at large. You could perhaps shift the amount of cultures that you need to obtain from this population. There's a world where the care model shifts. You can use the technology and the AI to create better detection, which could ideally perhaps lead to less of the current state. Is that right?
Yeah, the hope would be that we can target the use of antibiotics to infants who truly have infections. We can start the antibiotics earlier, which is associated with better outcomes, and then not treat infants with antibiotics who don't need them, because we also have learned that unnecessary broad spectrum antibiotics have negative effects, both in terms of changing the infant's microbiome and also increasing resistance among organisms in the NICU.
I'll just add that there's starting to come a body of literature that demonstrates that even 30 minutes delay in antibiotic timing is measurable in terms of mortality. So on the one hand, we want to get started as soon as possible in every case of infection. Unfortunately, that's also going to lead to false positives and initiation of antibiotics where ultimately it was unnecessary. And what we are trying to do with the Hero product is improve the timing of the initiation of antibiotics. But by the same token, we want there to be as few false positives as possible. Hence, a richer data set of prediction variables, including motion, may lead to models that are just as sensitive to be an early warning of infection while offering fewer false positives. And that's ultimately the goal, is to improve these prediction models to get started as early as possible with as few false positives as possible.
Essentially, a lot of what's motivating this work is really looking at movement as another vital sign. And my background is physical therapy, so I've always been fascinated by movement. But movement is something that historically has not been quantified, particularly in the NICU. So we're not the only people working in this area by any means, but we're interested in including a quantitative assessment of movement into the other current clinical assessments, hoping that we can increase our sensitivity and specificity.
There's more and more data coming out around the correlation between movement and other clinical conditions, or at least screening for potential clinical issues in kids and adults too. Thank you so much.
All right, thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and if you're so inspired, donate to your local children's hospital. All right, see you next time.
The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast.